So good afternoon, everybody. It's a privilege for us to have this session being taken by Dr. Shankar Prinja, who has himself been the author um, of a paper of a research publication that has been published in Lancet. Um, the intention for doing this webinar was that we wanted Dr. Prinja to explain in detail findings. And when I read about the findings in short, it appeared to me that the district hospitals in India would benefit a lot, have been benefiting a lot from the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And since he has done this work with great scientific rigor, and that is why this has been published in the prestigious journal of Lancet, we would request him to share his insights about what he founded, how did it do, and all these things will help us. All these things will help us know more about uh, how to improve the scheme in general, which the objective of which is to provide universal health coverage. So over to you, Dr. Prinja, for explaining your work. And then in the meanwhile, people can write their questions in the chat box. And after he completes a short presentation, all these questions can be taken. And we are very thankful for all of you who have joined this presentation. So we are recording this session because we will also put it on our social media handles. So over to you, Dr. Prinja.
Sure. Thank you very much, Vikramji. Ria, I hope that I can share my screen and I'll try to put up the presentation.
Yes, sir, you can share.
Okay. So just let me know when you can see my slides in full view.
Yes, sir.
All right. Thank you very much. And thank you to the organizers, Vikramji in particular, for having organized this public webinar on a recent publication that shows the impact that the PMJAY has on the public sector district hospitals in India. And this was a study that was recently published in the Lancet Regional Health Southeast Asia. So what we are going to discuss in the next about half an hour to 40 minutes is a bit about the background of how AB-PMJAY contributes as a mechanism to finance healthcare at the level of government sector district hospitals. And then in particular, I'll try and describe how we tried to measure the net benefit, the net monetary benefit that the district hospitals have through the PMJAY funding, which is paid to these hospitals as part of the patients of PMJAY beneficiaries that are treated in these hospitals. And then we'll have some reflections and discussions, and then the last half an hour we'll try and keep for discussions. As was described earlier as well, please keep typing in chat box your questions, because sometimes it may be difficult given the time for us to give an opportunity to everyone to ask questions. So please do putting in your questions or clarifications in the chat box. So to begin with, I'm sure that several of you would be very familiar with the overall construct of the scheme, which is Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. But just to say that this scheme, which is the largest in terms of numbers of largest publicly funded health assurance scheme in the world, it has a benefit package cover of about 500,000 per family per year, and does not impose any cap on the family size, age, or gender, considering the equity considerations. So all those families that have been identified as the beneficiaries of PMJAY, irrespective of the family size, they are covered under the scheme. And the states which have the prime responsibility for implementation of the scheme there is quite a variation in terms of how the scheme is implemented. So in quite a large number of states, the state governments themselves run the entire operations of the implementation, which is a trust mode. In other situations, which is relatively a minority now, it is the insurance company which is the intermediary between the government payer and the provider of healthcare services, which are public and private hospitals. And in a few states, it's a kind of a mixed mode, which means that certain value claims, which in most cases tends to be about almost up till 100,000, they tend to be taken care of by the insurance company, and any high value claim is settled by the trust. The patients or the beneficiaries who are part of the scheme can avail benefits in any of the empaneled hospitals across India, which includes a network of public and private hospitals, which is close to about 28,000 in total across the different states and union territories. And the entire transaction takes place in a paperless, cashless manner. There are no exclusions that are for any of the beneficiaries, given any of the pre-existing conditions that may be that the beneficiaries may be suffering from. And the overall number of procedures and the specialties that we have as per the most recent health benefit package, it comprises of about 1949 procedures, plus there are certain high-end diagnostics and procedures, etc. So the overall number goes up to about 1970, and these are cutting across 27 different medical and surgical specialties. So that's the kind of overview of the scheme that we wanted to just give. And this scheme has been very widely evaluated, and there is a lot of literature that is published on the impact of publicly financed health insurance schemes. That started in the beginning of around 2007 with the introduction of Arogyashri scheme in Andhra Pradesh, to then a national level scheme that was called as RSBY at that stage. And then there were several other southern states in particular, which came up with their own schemes. And more recently, around 5 years back, the RSBY was further revamped, and a new scheme was reincarnated, which was the Ayushman Bharat PMJAY. And as you can see, that there have been several of these evaluations which have been published across regions, individual states, or even national level evaluations that have focused on different aspects of the objectives of the scheme. But if we try and summarize that, what have been the broad themes which have been evaluated as part of the Ayushman, these evaluations, by and large, the most frequently evaluated theme of these impact evaluations have been the ones that are shown in this green on diametrically opposite sides. Coverage and access and financial risk protection. These are the two themes that have been the most commonly evaluated themes across all these impact evaluations. The other set of themes that have been evaluated includes from an equity perspective. That means either from a gender perspective or from income distribution perspective. That is the utilization similar across all types of income groups, gender, age, etc., and how well the schemes are targeted. And then the less often evaluated theme of these publicly financed insurance schemes have been around the quality of care that is delivered. And finally, one of the hardest things to measure has been the impact of these insurance programs on health outcomes. So these have been the broad themes across all the impact evaluations that have been published so far. And the limitations of this existing literature has been that majority of these assessments are from the pre-PMJAY era. And that makes it the generalizability of several of these studies quite a challenge, because if we look at several of the schemes that evaluated RSBY, the benefit package of the RSBY has been completely, there has been almost like more than about 15 times jump in the overall size of the benefit package, from about 30,000 per family per year to about 500,000. So that's quite a significant increase. And secondly, as we saw that the themes that were evaluated were largely around coverage, access, financial risk protection, etc. There hasn't been any specific evaluation from a financing perspective in terms of what has been the impact of these demand side financing mechanisms on the public hospitals. So that's been an area which has relatively been nascent in terms of the attempts towards any kind of evaluation. And why this becomes important to also evaluate is the fact that that we have a mechanism of paying the healthcare providers who are empaneled, which as I mentioned to you, could be a public hospital or it could be a private hospital. But each of these public or private hospitals are paid based on uniform rates. So there is no specific differentiation in terms of how a public hospital or a private hospital is paid. It's a standard package rate that comprises of which is a reflection of the actual cost of delivering care within a given package, and the same amount is reimbursed irrespective of whether it is a public or a private hospital. More recently, in April last year, 2022, we introduced a differential pricing system whereby the prices are differentiated across the different hospitals by the location of the hospital, which means the tier of the city where they are located, by the level of care, that means whether it is a secondary or a tertiary care level package, or by the type of the package, which means that whether it is a medical or a surgical package, again the weights are different. But as you can see that even these factors that differentiate the payments that are made to hospitals do not necessarily differentiate whether the hospital providing service is either a public or a private hospital. So whatever is a rate that is set for let's say a secondary care medical package in a tier 1 city is paid to a hospital, a government hospital, or to a private hospital that is located in that city. So that's a standard rate. And this construct of the scheme in itself becomes quite an advantageous situation for public hospitals. And the reason why we say so is because they already are financed through a supply side funding mechanism. And this supply side funding mechanism is the usual mechanism of financing public facilities, where the money is routed through the treasuries, which is used to pay for various supply side resources that are created in order to deliver services, whether it is, let's say, the staff that is placed there and the salaries that have to be paid, or the construction of the building, the equipments that have to be purchased, or other capital infrastructure that has to be created. And it also creates for a financing mechanism for provision of various types of supplies, be it medicines, consumables, or reagents, etc. And these are paid, these are funded either in kind, whereby there is a mechanism of central procurement and then that is supplied at the level of facility, government facility, or in certain cases, a certain amount of money is also available at local level, whereby local purchase of those additional drugs, consumables, etc. can also be undertaken. And this entire supply side funding route is used to create or make those facilities available where people can come in and walk in and get the access to services. There is no relationship of this funding mechanism with the volume of services delivered. So which means that a certain amount of norms are set for staffing, for capital, for the kind of drugs, etc. that should be available at a particular type of public facility. And all these things are made available at those facilities, irrespective of the footfall of the patients in that facility. Now, in addition to this supply side funding route, now each patient who is coming in as a PMJAY beneficiary, after getting the treatment, a claim is submitted and these public hospitals get paid through the PMJAY route in addition to the supply side funding that they are already having. And this mechanism of reimbursement for the claims that these public hospitals are submitted is now a variable type of payment, which is volume based. So the as many number of patients that you see, you get paid accordingly. Now, this additional funding source through the PMJAY that is now made available for every one patient that is seen by the public hospitals, becomes in a way a supplemental mechanism of financing, which could be used for a variety of different purposes at the facility level. So it could be used to augment the supply of medicines that may be in shortfall. So there could be stockouts of certain medicines, or certain medicines that are not part of, let's say, the EDL or not available at the hospital level, and those could be procured using the PMJY funding. Or there could be a situation that there are certain specialists who are not available. So those specialists could be hired on a case-to-case basis to come and perform in these public facilities. It could be used to even create the supply of certain services that were not available. Let's say, for example, there's a blood storage facility is not available, blood bank facility is not available, or dialysis services are not available. So there could be additional, or let's say intensive care services were not available. So you could put in, use this money to purchase, let's say, ventilators, or create certain ICU beds, etc. So that could be done. And this money could also be used to create infrastructure. So this could be capital infrastructure, could be diagnostic machines, or likewise. So this is the benefit that the supplemental route of financing can create. And there are various state level guidelines on how to make use of this money that the hospitals are receiving through the PMJY route. And it could be used to, as I said, to incentivize staff, to hire additional human resources for local purchase of drugs, consumables, etc., implants that might be required for the purpose of treatment, or for a general upgradation of the facility. And there are various state-specific guidelines that may vary from state to state. Now, given this background, and given the fact that this PMJY does introduce a supplemental mechanism of financing, what we aimed to evaluate was what exactly is the net additional benefit of PMJY funding for these public hospitals. So the idea was to evaluate the extent to which these public district hospitals have benefited from a financing perspective. And in real terms, it meant that we wanted to calculate the net financial gain, both in the current real world scenario, as well as make some projections about future. If there is an increase in utilization that can be created at the level of district hospitals, then how much additional gain in financial terms could be there for district hospitals. Now, in order to do so, in a very simplistic terms, the net financial gain that we computed for the district hospitals was estimated by deducting from the reimbursement amount that was received for any given patient treatment, the amount that the hospital has to spend in addition to the supply side funding. So we basically, what we do is, let's say there is a 10,000 rupees standard rate for a given package that is to be paid to a hospital. So that's your PMJY reimbursement. Now, what we want to deduct from this 10,000 is that what is the additional money that the hospital has to spend over and above the supply side funding in order to deliver care for this particular package. So we want to estimate this incremental cost of delivering that particular package of care. And this incremental cost is estimated by estimating first that what is the total cost of delivering the care. So for example, it's a procedure that it's a surgery that involves first some assessment, some diagnostic tests, then some procedure to be performed, then the stay of the patient within the general ward or the ICU setting, then certain medicines, etc. So all those things put together, that's the total cost of delivering that particular package. HBP means a health benefit package. But you deduct from that the total amount of cost that is already covered through the supply side funding route, which is the treasury route. So that's the essence of calculating the incremental cost. So just to further describe that, in a true sense, let's say this is the overall cost that a hospital has to incur in order to provide treatment for an X patient. Now this overall cost has a certain share, a certain amount of fixed cost, which is like the cost on the building, the cost of salaries that have to be paid to the doctors, etc. And then there's a variable cost which includes things like drugs, consumables, implants, tubings, catheters, or things like overheads, utilities, dietetics, laundry, etc. These are all component of variable cost, because these are going to differ. These are going to be additional incremental for every additional patient. Whereas the building that you have set, until you exhaust your capacity, it's going to remain a fixed cost, whether you're seeing 10 patients in that facility or whether you are seeing 30 patients in that facility. That's a fixed cost. Now, what is already covered by the treasury route, let's assume that the fixed cost, which includes the cost of the building, as I mentioned, or the cost of the salaries being paid to the doctors, etc., that is a fixed cost, because that's not something that, so you did not hire another additional doctor in order to treat the PMJY patients. You had the same doctors, same nurses, same staff that were used to treat the patients. However, there were certain elements of the variable cost, which included things like drugs that may not have been available, implants that you were earlier asking the patient to buy from outside, or things of that nature. These are the things that are not currently covered through the treasury route adequately, and that's only because it's not that it should not be covered. It is that there is some shortage in the availability of drugs, consumables, etc. And as a result, these are not covered. So the incremental cost is actually this part of the variable cost, which is the additional cost to pay to treat a given patient within the public hospitals. So we then estimated the net financial impact given this kind of a scenario, and we did this in 3 different scenarios. So this table helps you to understand this in a much better manner. So we basically estimated from the cost. We said that, okay, in the real world scenario, the public hospital already has human resources, capital, equipment, and furniture, which are completely covered by the supply side treasury route of financing. Let's assume that for each additional patient that is treated, you need to have consumables, utilities, and the overheads that have to be paid in addition. The drugs, we estimated that there is almost like 2/3 of the drugs are available in the facilities, and there is a shortfall of about 34%, which you have to procure additionally if you were to provide really cashless treatment to the PMJY patients. And this comes from another recent study that was undertaken in 3 states, which showed that the availability of drugs in public facilities is close to about nearly 66%. So that's our real world scenario, where we say that this is the actual incremental cost, and this should be deducted from the payment that the hospital receives in order to estimate the net financial gain. We estimate a more conservative scenario of the net financial gain, where we say, okay, what if all the drugs were also to be procured completely irrespective of whatever was available in the public facility? So all of drugs, all of consumables, utilities, overheads, etc., were to be paid extra for each PMJY patient that was to be treated. That's our second scenario, which is a more conservative scenario. And the third is the most conservative scenario, where we believe that, you know, your public hospitals are already constrained in terms of their capacity. And what it means is that the current human resources are also very inadequate, and they are operating already at, let's say, 100 or even 110% bed capacity. And so even the current human resources are insufficient. So you may need to even augment the existing human resources in order to really provide patients to the, in order to provide care to these the PMJY beneficiaries who are walking in to get the care. And so what it means is that in this last most conservative scenario for net financial gain, we say that all of this is the additional incremental cost of providing care to PMJY patients. And in addition, you will also have to pay, you will also have to, in a way, double the human resources, which will have to be paid out of the PMJY. So this is also the incremental cost of paying the, of treating the PMJY patients. So this is the most conservative scenario. And in all these 3 scenarios, we try to estimate that what's the financial gain. So as you can see, we basically need 2 types of data in order to estimate. So this is just, again, a more mathematical notation of the same explanation that I've tried to show, that first we estimate the incremental cost, of providing care to PMJAY beneficiaries, and then we estimate the net financial gain. And the net financial gain is estimated at the overall level for all the district hospitals. We estimate it at the level of per district hospital per year. And we also estimated that for every bed, what is the net gain for the public hospitals. And we estimate this at the current level of utilizations for district hospitals. And in scenarios where the utilization at district hospitals go up, in each of those scenarios also, we try and estimate this. So as you can understand that we basically are looking at two major sources of data in order to estimate this net financial impact. The first information that we need is the claims information. That means how much are hospitals getting from PMJAY. And this assessment was done for using the data that was obtained from the NHA in 2019 on the claims. And the reason why we used 2019 was because this study was being undertaken in 2021. And the subsequent years, 2020 and 2021, were kind of COVID years where the utilization was partly affected by the COVID pandemic. So we used the data from 2019 from the claims data of NHA. This data pertained to 154 hospitals which were empaneled at that time within the PMJAY. And these included about 42 district and 112 sub-district hospitals. And this comprised of almost 10 lakh claims, which were for about 400 health benefit packages. And the reason why we limited to only 400 health benefit packages was because the data on cost was correspondingly available for these 400 health benefit packages only. So that brings us to the second part of the data that we used in order to estimate this net financial gain. And this data on cost was obtained from a nationally representative data that was being collected as part of a study being undertaken collaboratively by 12 to 14 institutions across India, which was funded by the Department of Health Research, which is the CHSI study. And as part of this study, besides other hospitals that were also costed, there were about 27 district hospitals where cost data collection was undertaken from 9 states. So in each of these 9 states, there were 3 districts where the district hospitals were sampled, and the entire data on cost of providing healthcare services in these district hospitals was collected. And based on this, eventually, the cost of delivering 400 health benefit packages in 5 surgical and 2 medical specialties was estimated. And these were unit costs, which were available in a very disaggregated manner. As I showed you in the previous slide, that means data separately for each health benefit package was available as how much was spent for salaries, for capital, for diagnosis, for equipment, drugs, consumables, overheads, utilities. All those disaggregations were available for each of these 400 health benefit packages. And just to give you a bit more into this particular source of cost data, which has been very widely published as well in terms of the protocol of this particular study. And this study has been very significantly subsequently utilized for setting the and revising the prices of the health benefit packages. We do understand that there is a lot of heterogeneity in cost. It's not the cost of providing care in one area is not similar to another area. And as a result, we used several sensitivity analysis, one of which incorporated the changes in the prices of drugs and changes in the prices of the recurrent costs. So, and these were done through Monte Carlo simulation methods. And then eventually 95% confidence intervals were estimated. So finally, coming to the findings of this particular study, where we tried to evaluate that what's the level of gain from a financial perspective. We first tried to show some of the descriptive findings. And this slide basically tries to show the proportion of the total public sector claims that were being submitted from the district hospitals in each of these states. So, and the blue bar represents the number of the claims, and the orange bar represents the value of these claims. So what it means is that in the state of, for example, Kerala, in that particular year, using the data that was available on the claims, we found that about nearly 1/5 of the total claims which were submitted from public sector facilities were from district hospitals. So when I say that 1/5 were from district hospitals or sub-district hospitals, the remaining could have been from tertiary care hospitals, could have been from some central government funded hospitals that are located within the state, could be from even CHCs, or even if there is a primary health center also that is empaneled, that could also be part of the 1 minus this value. And similarly, when I look at this 13.5%, what it means is that of the total claim value that is submitted by, or that is paid to public facilities in that particular state, what proportion is actually paid to the district hospitals. So this shows that there's quite a lot of heterogeneity, where some states, the district hospitals constitute close to about nearly 1/5 to about nearly 30%, but other states have some low share of the overall claims that are from within the public sector that are utilized at the district hospital level. Now, this is another representation of the share of the public district hospitals, but this is from within the packages that are classified as secondary level packages. So those packages that can be classically categorized as secondary care packages, what is the share of these, the utilization of these packages within the public sector that is availed at the level of district hospitals? So in a way, this also reflects that there could be the scope of increasing the utilization of district hospitals within the public sector is actually higher, because these are those packages that should be availed at the level of district hospitals. But given the fact that there is relatively little or no gatekeeping, a lot of these packages, even which are secondary care packages, continue to be utilized at tertiary care facilities as well. This slide basically shows the same kind of two graphs which I showed you earlier, which were earlier for stratified across states. Now these are stratified across the different specialties. So what it shows that the bulk of the overall utilization for district hospitals primarily takes place in three major specialties: general medicine, obs and gynae, and the general surgery. So these are the three particular specialties that comprise of the largest share of the total claims that are paid to district hospitals. And the same is the situation if we drill it down to the for those packages that are classically the secondary care packages. Again, the share of here, in fact, the share of the general medicine goes up much significantly higher. So which means the general medicine departments across district hospitals tend to be much more functional, and they are taking care of bulk of the overall secondary care needs within the public sector. And that's particularly only looking at the value of the public sector claims. So now moving from that to the prime objective of the study, which was to look at the actual impact on from a net financial perspective. And this table basically tries to show in each of those three scenarios. So this was our real world scenario. These two are the more conservative and the most conservative scenario. And these the values that we see here are represented in millions, which show that what is the annual gain for all the set of these about 154 hospitals that were empaneled in PMJAY during the year 2019. So if we translate that into simply in crores, which is more easy to understand sometimes, we can say that the value of the net monetary benefit at the level of district hospitals for all the claims that have been utilized under PMJAY could range from about nearly 183 to about 294 million crores, given the different levels of utilization. So if we keep on increasing the level of utilization, then the value the net monetary benefit at the net financial benefit at the level of district hospital can go up. Currently, it is about 183 crores. It can go up to 294 crores. And even in the most conservative scenario, where even the human resources would have to be kind of doubled in order to cater to the PMJY services, even in those scenarios, there is still a net positive financial benefit for their public sector district hospitals, which can vary from about nearly 113 to about 181 crores. Now, this may become less it may convey a particular picture which is only representative of those set of hospitals that were empaneled during that period. But this becomes even more clearer if we look at the situation within a given district hospital. So this is now the level of an net annual financial gain per district hospital. And again, the table format is the same. You have the real world scenario here. You have the two conservative scenarios that are listed in the next two columns. The values are again represented in millions. So you can deduct a decimal to the left in order to understand in terms of crores. So the net financial gain per district hospital could range from about 1 to nearly about 2 crores, given if you increase the level of utilization. So the current average utilization is about 40%, and it could go up to as high as nearly, it could double if you increase the level of utilization. Now, this is something that that needs to be understood in the context of what is the overall level of financing at the district hospital level also, in order to understand better what it means to have this much amount of extra net financial benefit to the district hospital. So just to place this in perspective, the recent national health accounts shows that there has been this much amount of spending at the level of district and sub-district hospitals. If we look at the total government expenditure and we look at the share of the secondary care that is done. So this is the overall amount of money that is spent at the district and sub-district hospitals as per the national health accounts. Now, this is again inclusive even of the capital expenditure also, because the NHA, the national health accounts, does also factor in the capital expenditure. So what it means is that the government expenditure per district hospital comes to about nearly 14 crore rupees. And the net gain in the revenue that we are estimating through PMJY per district hospital is in the range of 1.2 to 1.9 crores, which means that the district hospitals, in addition to their supply side funding, stand to gain in a range of 8 to 13% higher as compared to what they are currently getting from their routine treasury route supply side funding. So this itself, I think, would be quite a substantial, given that the extent to which this money could be used in order to augment A, the level of service provision, B, increase the range of services, C, improve the quality of services. So that's the amount of money that is additionally, in a way, net incremental, net financial gain at the level of district hospital. We also estimate this gain at the level of per district hospital bed also. And this per district hospital bed, we estimate again, this ranges from about nearly 53,000 to about 86,000. So per bed, the net financial gain that the hospitals have is in this particular range. So given these findings, let's look at what implications does it have. The first thing is that this particular piece of research was the first to evaluate the financial impact of any publicly financed health insurance scheme on the public health system. So in a way, this is a kind of a sort of conclusion that how the demand side financing mechanisms can also be used in order to strengthen the public system. So these district hospitals and sub-district hospitals, the extent to which they are benefiting from in financial terms from the PMJAY payments is again a reflection that a demand side financing mechanism is able to supplement this particular public system. We do acknowledge that whatever estimates that we have presented in terms of the net financial gain are actually an underestimate. So the true magnitude of the financial gain is actually likely to be much higher than this. The reason why we say so is because whatever we estimate as financial gains are only limited to a set of potential 400 health benefit packages in 7 specialties that could be accessed. Now, there are more than 400 health benefit packages that potentially can be utilized at the level of district hospitals. So that is number one. Number two, the overall at the national level, whatever we estimate in terms of the net monetary benefit is only limited based on the set of 154 empaneled hospitals in 2019. Now, this number alone has gone up beyond about 600 as of today. So which means that the annual financial benefit that we estimate at the overall level for district hospitals is significantly much higher. Although the per hospital benefits that we estimate could also be higher, given the fact that we are only looking at the benefit that could come from these 400 plus health benefit packages. And the reason why we had to limit ourselves to only 400 health benefit packages was because the data on cost in a much more disaggregated and granular manner was available or restricted to just these 400 health benefit packages. So the true impact of PMJY on district hospitals or public system is likely to be much many-fold higher than what we present as part of our estimates. So this, again, in terms of what does it have in terms of future recommendations, etc. We do recognize that there's a significant concerted effort by the government in strengthening the district hospitals, and several of these district hospitals are being converted into medical colleges with augmentation in the availability of services, availability of specialists, and also the improvement in the capital infrastructure, etc. So in that sense, the additional PMJY reimbursements, A, could go up even further, and B, could be also used to further augment this public infrastructure that is being strengthened. We do recognize that this continues to remain in place, and this should always remain a supplemental route of financing, and there should be no substitutive effect that this should start to play, which means that eventually the supply side treasury route should continue to remain the way that it is, and PMJY funds become a kind of a supplemental route. And so there should be no constraining in the overall supply side financing that is continuing to take place. And which is also reflected in the fact that the aspirations of the government to further strengthen district hospitals to medical colleges, which means the supply side financing is continuing to go on increase in an increasing trajectory. The second important implication from our study is that if, as we showed, that as you increase the level of utilization, the net financial gain that you have continues to increase. So which means that there is a role for gatekeeping the service utilization or building in some mechanisms of referral or having some kind of policies for reserving certain secondary care packages at the level of district hospitals. Now, this is something that is not something that is new to majority of the countries across the world that have mechanisms of demand side financing. And this is also important from the overall perspective of improving the efficiency of the overall health system, because you do not want to incentivize the provision of secondary care at tertiary care facilities, because tertiary care facilities currently are crowded and are not able to deliver the intended goal, A, because of the fact that there is relatively very little gatekeeping, and as a result, every patient walks into a tertiary care facility as well. More so from a pure economics perspective also, if there is a secondary care procedure that can be performed at the district hospital, that is definitely going to cost less as compared to what it will cost in a tertiary care facility. And as a result, it's from a pure economic perspective also, it is more cost effective and more efficient to provide that particular procedure at the level of district hospital. The other advantages of gatekeeping with adequate upgradation of infrastructure also is that there is, given the fact that these majority of these district hospitals and then the sub-district hospitals are located in tier 2 and tier 3 cities, this is going to make the care more accessible to areas where there is relatively there is a relative dearth of facilities. And obviously it will decrease the burden on the public sector tertiary facilities. And as I mentioned earlier as well, that it's going to be a more efficient use of resources, as we do recognize that the overall cost in district hospital is less than a tertiary care facility for the same procedure that may be performed at either facilities. The second possible policy lever that it can open up is the fact that there could be a differential pricing as well. And differential pricing by the level of care, which means within the public facilities for district hospitals versus the tertiary care hospitals, or maybe differential pricing across public or private facilities. However, there is it is the differential pricing by the type of provider, which is public or private, would not be a beneficial idea, given the fact that this will offset the benefit that is currently we are seeing for the public facilities through this kind of a differential pricing. However, if the differential pricing could eventually be considered for district hospital versus a public sector tertiary care hospital, then this can bring in greater efficiency. And this could also lead to a more optimal and a more efficient use of resources by the public payer, because whatever is going to be the saving is going to be the saving for the public payer eventually. And the same money could be used to further strengthen either the access to care for a larger number of people, or to further strengthen the public hospitals as well. And we have seen even from live situations as well, that how the public hospitals have significantly benefited from the PMJAY funds that are made available at these facilities, which is directly proportional to the level of utilization in these public facilities. And these are some of the photographs that I'm showing you from a district hospital, a Sadar hospital in Ranchi in Jharkhand, where there has been a significant upgradation of infrastructure through creation of the additional wards, ICU beds, and overall improvement in infrastructure that one can see from these pictures. And this is again another depiction from a hospital located in Gaya, where again the availability of PMJAY funding has been used to create services such as a blood bank, or improving the availability of services and improving the infrastructure, etc. And we also do recognize that this is a state-specific. Lot of policies tend to take place at the level of facilities, at the level of states, and different states have issued different guidelines with regards to use of public the money that is available at the public hospitals to sort of incentivize the staff, or to build infrastructure, or to improve service availability, etc. Or in other instances, this has been used to create a referral linkage pathway, whereby there has to be some kind of gatekeeping by the public facilities. And this is something that is already in operation in Karnataka state. So some of the potential policy applications that I was trying to highlight are things that are already in place in certain states, and certain states are trying to come up with different innovative ways of further strengthening the public hospitals. So with that, I'll stop here, and we can open up to questions and clarifications, etc. So I'll stop sharing my screen here, and perhaps we can I can look at the chat box to begin with.
Thank you so much, sir, for the very insightful session. So initially we have a question from Mr. Ajay Tandon. I'm unmuting you, Mr. Ajay.
Hi, thanks. I'm not sure. Can you hear me okay?
Yeah, we can hear you.
Hi, thanks for that I think in part you answered the question I'd asked Dr. Punjab. One question I had was, before you correct for the increase in cost due to higher utilization and things like that, what is your sense as to what is the incremental public financing impact of PMJ at public hospitals? So would that be like 20-25% of the supply side financing before you do any correction for the added costs from higher utilization? That was my question. Thanks. But great presentation. Thank you.
Sure. Thanks, Dr. Ajay. I think that's a very important question. So we didn't empirically estimate that what exactly would be the impact without a correction of the net benefit. But I mean, I can say off the back of the hand calculation that what we estimate right now as something that is in the range of 8 to 15%, which is the kind of net incremental benefit as a proportion of the total supply side funding. If you don't make that correction, it's likely to be somewhere in the range of 20 to 25%. But again, this needs to be empirically estimated, and that's something that we hadn't reported or done at the time of publication of the paper. I can, till the time there are others are trying to ask the questions, I can just quickly scroll through the chat box. There's a question that in the estimation of the financing through the treasury route, does it include or the PMJY funding or not? The answer is that it does not include the PMJY funding. So the treasury route financing was estimated through so it doesn't have a valuation of the PMJY funding. It's estimated without that. There's a question that can we call it as a financial gain for district hospital, since the incremental cost of delivering services is reimbursed, which was a cost to the district hospital? So yes, so in a way we are saying that it's a financial gain to the hospital, but the reason why we say it's a net financial gain is because we also deduct the amount of money that the hospital has spent if it would not have treated a PMJY patient. So the counterfactual that we're looking at is the additional cost that the hospital had to spend in order to treat a PMJY patient. And so after deducting that cost, this is the net financial gain that the hospital has had. There's another question that can we do the same study at the state level for all government hospitals as now compared to 2019, and the scenario is different, and majority of the government hospitals are doing claims, so the study will be more helpful in case the number of claims and services have all gone up. So I think that that's a very pertinent question, and that's why I particularly clarified that whatever we report as part of this paper are still much modest estimates of the actual financial impact of the PMJY on district hospitals, because the number of district hospitals that are empaneled has gone up. Secondly, what we estimate as financial gain is also limited to just a certain subset of those 400 health benefit packages for which we had the cost data as well. Whereas the district hospitals potentially do also include or treat other health benefit packages where we did not estimate how much was it the additional gain for those particular packages. So I think that yes, there is if the same study was to be done again, it would perhaps show you a significantly higher estimate. Definitely the scenarios have changed from 2019 to now. There could have been, in certain states, there could have been a much greater increase in the share of district hospitals as well. So that's something that we can look at. There's a question that costly injections like globulins, thymogam, etc. are not included in the treatment under the scheme. So yes, you're right that there are certain therapies or certain services that may not be part of the health benefit package. But I think that there are more new high-end drugs that have now been included as part of the new package, and those do cover up for some of the deficiencies of the previous versions of the health benefit package. There's a question by Dr. Indrani which says that how would you ensure that the financial gain is being used up efficiently by the hospitals? Are there some guidelines, or are the hospitals left to decide how to spend the funds? I think that's a very, very important question, and I'll answer the second part first. Yes, there are state-specific guidelines. So while the NHA does issue some advisory sort of guidance, however, the states have their own independent guidelines that they issue. I showed one example from the state of UP that they had this state-specific guideline on the utilization of this money, but then these guidelines vary from state to state. So MP does have another guideline which may have different sort of share that they allocate of the PMJAY funds that are available that could be used for either incentivizing staff. But broadly speaking, all the guidelines generally allow for use of this public the PMJAY funds in district or in public hospitals for A, incentivizing the staff, B, the procurement of drugs, consumables, implants that have to be provided to the patient. C, it also allows for general infrastructure upgradations. So those are three major entities that are generally available. But I do agree, ma'am, that your first question, that how do you ensure that the financial gain is being used efficiently by the hospital? Now, that's a very important question, and that's a kind of reality check. Yes, ma'am, if you want to unmute yourself and please speak up. Riya, can you unmute Dr. Indrani Gupta?
Yes, I'm doing that.
Shankar, this is a very good study, and thanks a lot. It was a great presentation. I mean, I'm sitting here thinking that, the treasury route, the funds that the hospitals have been getting over the years, we know there's so much of inefficiency in utilization, and that has been a big downside of our public health care system. If this is the kind of amount of money that they are going to accumulate, I mean, I'm really now getting worried that, we are going to be wasting some good public money for tax money for, if the hospitals are as inefficient as they used to be. Unless you can assure us that there are norms in place that the hospitals are not allowed to accumulate the funds, and so that's where I came from. So we don't want good money to be thrown after the bad money, that kind of thing. Okay.
Sure, ma'am. I mean, I think point very well taken, and which means that there's more work to be done definitely at the level of facilities. A, to build that kind of public sector autonomy in order to make better use of this money, and B, to be able to use that efficiently as well for the services or the upgradations that are genuinely necessary. There are several different models in which this public money tends to be made use of. So one model is that the hospitals are left to make use of this money. In majority of the states, the hospitals do get a share of this money. In some other states, it's also that fact that the money that is to be paid per package to public hospitals, a share of that is actually held by the central agency, and that money is then made use of in order to have some kind of a responsive resource allocation. So it's not just one hospital that has a very high utilization that continues to get a lot of more money also, but given the fact that you have this some portion of this corpus made available at a central level, allows you to do some kind of risk adjustment across other hospitals which may not have enough resources, but where perhaps an augmentation of this additional capital could improve the utilization of services. So definitely some is there, but maybe we can definitely benefit more from more evidence from which can be generated through additional studies, and we'll very much welcome if you can help us support that as well. So thank you very much. There are other questions. So if there's a question on can you tell that PMJAY support the diagnostic services as well as, say, if CT scan in district hospital? So yes, there are instances where there are guidelines within each state which allow the district hospitals to engage in procuring additional equipment or services that may be made available. So we have seen public hospitals where procurement of ICU beds, dialysis machines, ventilators, etc., have been put in place by using the PMJAY funding. So I think that the answer to this question is yes, and there could you should definitely engage with your state health agency to clarify more on this particular issue. Again, the next question is the same as, please share the ways of utilizing funds in hospitals. So maybe as a follow-up of this session, what we would do is that, and I'll encourage our team to maybe send out all available guidelines that exist to all the people who have participated in this session, or to at least all the public hospitals that are empaneled under PMJAY, so that dissemination of this information for use of the PMJAY funds could be made better. There are some questions in the chat box, but those questions are pertaining much more specifically to some health benefit packages, etc., which I think we can have a separate session. So I'll skip those questions. There's another question which is specifically on the pricing part, and the package rates do not account for the fixed pricing which are already provided to public hospitals. So I think this question, I would just respond by saying that the current health benefit package, which has been announced in 2022, has made several changes in the pricing structure, and I'm not sure which state do you belong to. So there's a question by Dr. Astha Arora. So I'm not sure which state do you belong to, and for which state is this question pertaining to, but and there are some states which may not have yet migrated to the new health benefit package, but several of the states have done, and their new revised pricing is available. So there is Dr. Sheena has responded saying that there are some NHA guidelines based on case studies of 4 states, and also desk review of guidelines from 16 states. Dr. Sheena, would you like to unmute yourself and maybe you can say something on this? If there is a Ria, if you can unmute Dr. Sheena Chhabra.
So it's done.
So thank you very much, Dr. Pinja. Fantastic presentation. It's really good to see how we can use demand side financing mechanisms for strengthening the public sector. So, based on this, just at the time when PMJ was launched 4 years back, that's the time when we had done 4 state case studies looking at, Tamil Nadu, Chhattisgarh, Gujarat, and I'm forgetting which was the 4th state, but we had done in-depth studies of 4 states to look at what was really happening with the claims revenues that were generated in their health insurance schemes in these states. And one thing which it was very impressive to see, like for instance, in Tamil Nadu, under the CMCHIS scheme, we could actually see, especially, medical college hospitals and district hospitals, they had used the money for upgradation of facilities, for getting equipment. There were, like I remember Stanley Hospital, for instance, there were wards, like the cardiac ward was, they had been able to upgrade the equipment as well as provide staff incentives. And they also had an expenditure tracking system where things were audited, coming to Dr. Indrani's point. And looking at some of those practices, looking at what was happening in 16 other states, I think I've also shared the latest guidelines that NHA has, and these are also available on the NHA website. on the fund utilization in government hospitals. NHA developed these guidelines in terms of fund use, and also giving on how these monies can be used and how these monies should also be accounted for. Because sometimes what also happens is government hospitals don't use this money because they also fear that if we use this money tomorrow, there may be a problem, or the guidelines are not very clear on how it should be used, so it remains unused. So there are many different ways in which this can be used, and some of that is also documented in the annexures in the guidelines itself. So I just wanted to share that. Thank you.
Thanks very much, Dr. Sheena. Ria, I think there's one hand raised, and it's on the chat box also. They've requested to unmute. It's NCD Cell District Janjigir.
So we have unmuted them.
Hello, good afternoon, sir. This is Dr. Raj from Janjigir, Chhattisgarh.
Yes, doctor.
Sir, is there any skill or service like existing district hospital has been developing into medical college, but they are developing their services or diagnostic services like CT scan by their own fund, like district mineral development fund. Is there any provision to upgrade the district hospital service, diagnostic services mostly for that?
I think we weren't able to very clearly hear you. There's some not very good signal. But I think that if your question was pertaining mainly to the use of public funds through PMJY to be made use of for upgrading the diagnostic services, then the answer is yes. And I think for more details, you could refer to the guidelines that might be available in your particular state, that how these funds can be utilized, because we don't want to specifically suggest a generic guideline, because each state has also issued their own specific guidelines, and that would be the one that would be more relevant to you. So, but the general answer is yes, it can be used to upgrade the diagnostic services.
Okay, thank you very much, sir.
So there is a question in the chat box by Sujoy Pal. How will the financial benefit translate into financial protection for households and give financial benefits to patients?
Okay, I'm not able to see this, but maybe what you've said, I can just respond based on that. So see, one of the things that I mentioned to you, that how the financial gains can help in further improving the financial risk protection. See, if there is an increase in the overall level of financial, if there's a net financial gain at the public hospital level, and the examples that we also showed in the subsequent slides as pictures, etc., and the subsequent illustrations given by Dr. Sheena and Dr. Rajesh Jha has also mentioned in the chat box, where there have been several examples in different states where public hospital, the level of services, the range of services, they've all been expanded based on this additional source of revenue. And if you increase your service delivery basket, or if you are able to service more number of people, then obviously that has an impact on the reducing the out-of-pocket expenditure and improving the financial risk protection. So indirectly, it does translate to that. The other way that I also indirectly referred to that in the discussion also while presentation was that if you're able to save a certain amount of money through a differential pricing by paying the district hospitals slightly lesser than the public sector tertiary care hospitals, then whatever you are saving, in a way, that money, given that the overall resource is finite, could be used to service more people then. And if you're able to service more people, then it means that you are able to improve the health of more people, as well as reduce the out-of-pocket expenditures and offer financial risk protection to more people. So automatically, each of these routes of the manifestation of this net financial gain has implications in terms of improving the financial risk protection. I think Dr. Rajesh has.
Yes. So you are on. So we have asked you to unmute. So can you please unmute yourself?
Hi, can you hear me?
Yes, sir. Yes, sir.
Good afternoon. Thanks, Shankarji. Excellent presentation. Picking up from the points that you and Dr. Indrani Gupta were, talking about, I think in terms of the larger agenda, working around capacities related to fund utilization is extremely important. And at the state level, when we've engaged, there's always been this, debate around, is it the mandate of an SHA, for example, at the state level? We don't manage district hospitals. They are not under our, administrative jurisdiction. Let the NHM or the Directorate of Health Services handle that. And so this is something which may need policy attention. While, I mean, we have excellent examples, from Tamil Nadu, some very good examples of fund utilization in Chhattisgarh that Sheena referred to, which we had documented in our report in 2020. I mean, there are states with, relatively weaker governance capacity where fund utilization is a real challenge. And this becomes a serious, concern in an environment where across majority of the states, we do not even have a system for the hospitals to regularly report on the receipts and the utilization of insurance claim revenues. While on one hand, it's extremely important for the hospitals to have autonomy at the facility level to be able to spend, based on their need, some minimum, accountability frameworks have to be put in place. We know through previous work what kind of, uncontrolled, or I would say, relatively unregulated, RKS spending environment is in the public system, despite the statutory reports and other things that are there. So that's something that, I would want to, really highlight in terms of the policy attention at the national level and who literally owns this mandate, NHA, SHA, or the health departments of different states. And if it is the latter, how do we bring them on board on this issue? Because one aspect, last thing, Dr. Shankar, is that, in the same piece, when we were looking at PMJ revenues as a share of total flexible money at the hand of a district hospital, other flexible pools, either from NHM, RKS own earnings, and if I'm not mistaken, it came to around 45 to 50%. PMJ contributes to 40 to 45%, 50% of the total flexible money outside the treasury route. And this is a significant, pot of money, as Dr. Indrani just mentioned. Yeah. Thank you.
I think, sir, these are extremely important pointers that you have given, and extremely important agendas for us to work as well. So the first is around trying to build capacity at these public facilities in order to be responsive to utilize these funds, and B, to build the accountability frameworks. I think both of these two are extremely important areas. The third point that you mentioned is who becomes the custodian, or in a way kind of enabler, whether it is the NHA, the SHA, the NHM, or the state directorate for that matter. In that sense, actually, earlier last year itself, both the NHA and the Ministry of Health had tried to work on trying to revise the guidelines for the RKS fund utilization, and how developing some mechanisms of continuum of care could be established. And this PMJAY funding, how, I mean, the fund flow, governance structures, channels, and the utilization guidelines, all of these things were to an extent drafted. And I think that we'll have to get back and see that what's the level of implementation of those. But yes, there has been some work which was done last year. It's still, I think, yet to percolate down to all the states, those guidelines, etc. But definitely you point us to a very important area, and we'll definitely take care of that and work in that direction. Thank you very much.
Do we have any other questions? Sir, you are on mute.
I think there was one more hand. Someone, Dr. Arun, somebody had raised a hand that I saw.
Sir, I gave permission to them. They can unmute himself if he wants.
Yes, sir. Please state by Jaya.
Actually, we have given permission to everyone. All the participants can unmute themselves. So if anyone have any questions, please ask.
So I think we can, Ria, if there's no more question, then we can perhaps close the session. Thank you very much to all those who have participated in this session, and it's been an enriching discussion, and we've got very important feedbacks and very important recommendations. We'll continue to be in touch with you, and as has been highlighted, that there are a lot of areas to further work and strengthen the system in order to make this this more meaningful again for the public system. So thank you very much.
Thank you so much, sir, for the session. Thank you so much, everyone, for joining.
Thank you. Bye.